Hi. Hi, good afternoon, everybody. I'm Dr. Sam here, consultant pediatrician from Columbia Asia Hospital, Petaling Jaya. So today I'm going to talk on common skin conditions in children. So why I would like to choose this topic because I think this is a very common presentation to our primary care physician and after the respiratory illness maybe. So that's why I would like to talk a little bit on, sometimes because I also get some referral from our GP colleagues on some of the skin condition on children. And during my practice in general in government sector, we also since there is a few case of dermatology case and skin condition case was not picked up properly, especially even though seems sometimes it's a simple case, but because dermatology conditions in children can be quite mimic in each other. That's why sometimes we can have misdiagnosis, especially in children. So today, I'm going to talk on this common skin condition in children. So this is the outline and also objective of our presentation today. First, I'd like to introduce types of common skin condition in children and its spectrum, especially in primary care setting. And I would like to also introduce what is the difference between types of skin conditions in children and what is the difference. And I would also like to suggest some of the clinical management of skin condition in children. Okay, so this is the outline of our presentation today. First, I would like to talk on a little bit on skin and its function. How about the newborn skin condition? Next will be our superficial mycosis, which we commonly seen is a tinea, Pityriasis Versicolor, Cutaneous Candidiasis. And next will be the Nappy rash, Seborrheic Dermatitis, Atopic Dermatitis, or we call eczema, and scabies, and last but not least is impetigo. So let's talk a little bit on skin. What is skin? Skin actually is the largest organ of our body. So it has a lot of functions, which the first one, they protect us from pathogens and even excessive water loss. Because skin have a very good barrier, especially in the epidermis layer. It will protect us from the pathogens and also excessive water loss. Secondly, this will also help us to regulate our body temperature, either by using a vasodilation or vasoconstriction. So this will help us to regulate our body temperature by excessive heat loss. And next will be, it provides us sensation of touch, heat and also cold. And not to forget also vibration and proprioception, also very important for skin. Next, part of the synthesis of vitamin D also was undertaken by skin. So we can see that skin is a very important function. Next, so let's talk a little bit on the structure of our skin. First, we have three main layers. The first will be an epidermis layer, and the second will be dermis layer, and the third will be the most deepest one will be the subcutaneous tissue, or we call hypodermis. So these three layers have their own function, and we can see that epidermis is the main layer, the first layer, which consists of stratum corpusum, stratum germinatum, and stratum spinosum, and the last will be the stratum basale. So these four layers of epidermis is important, and most of the skin condition actually is happen in the epidermis layer. So the dermis layer, normally they have a lot of blood vessels, and also some subsequently will be a subcutaneous tissue which that contain fat, and also our hair shaft, and also our sweat gland. So our skin color actually is created by a cell called melanocytes. This melanocyte will produce a pigment called melanin. This melanin actually is in our epidermis layer. So this epidermis layer, which they have different quantity of melanin, will determine your skin color. So let's talk on the newborn skin condition first. So actually, most of the skin condition in newborn, they are benign. So there's a few main questions. Make sure your baby, there's no fever. I always will remind us, our colleague, make sure the baby no fever, the baby is active, feeding well, he have a normal urine output and also normal stool output. Then, most of the time when the parents present you with a complaint of skin condition, actually, then most of the time is these few criteria, they are normal, means most of the time the skin condition will be a normal one. So let's look at the first picture on your left hand side. This is we call pustular melanosis. This pustular melanosis you will see here, there's a multiple pustule located. Most of the time they will be distributed over the forehead, sometimes over the limbs and also the trunk. So previously we received some of the referral from our clinic kesehatan or even hospital emergency department. They will tell you this, hey doctor, I want to refer a case. Looks like there's a septic spot. So when you listen to that, actually you will be very worried. So septic spot actually is not a proper name. We call that because most of the time, if the baby is well, no fever, active, and most of the time there are no septic spot actually in our dermatology and even in our childhood's condition. So most of the time it will be pustular melanosis. Then next is a not uncommon one, which is a miliaria. So this is quite similar to pustular melanosis, but this is a much more fine and pinpoint. And also there's a very small pustule. Mainly they are located at the trunk, and also they also involve the axillary area and also the inguinal area. So normally in the creases. And normally this is due to the immature of the sweat gland of the baby. Because of the immature of the sweat gland, so this will become a miliaria. And sometimes overwrapping the baby can make the condition worsen. So that's why when the patients bring in the baby, my suggestion will be, besides you have to make sure the baby is normal, you also need to ask whether the condition of the house is it too hot or the baby is overwrapped. Sometimes it's a proper ventilation or not proper wrap the baby. The heat rash actually will improve. So most of the time, for these two skin condition, we no need to do anything, and most of the time they'll resolve within 1 to 2 weeks of life. I think the right upper hand one, all of you will be quite familiar, and this is the most common skin condition, even though the name seems to be very malignant, like erythema toxicum. But definitely this is a normal skin condition for a baby. So next, we'll go to superficial mycosis. Okay, superficial mycosis actually consists of three main disease, which is dermatophytoses, or commonly we call tinea or ringworm, Pityriasis Versicolor, Cutaneous Candidiasis. So all this actually is due to fungal infection of the superficial skin. So let's talk on dermatophytes. So dermatophyte actually they consist of three main one, which is microsporum, trigophyton, and epidermophyton. So this can infect any keratinized epithelium, either your hair follicles, your nails, or any skin on your body. So the clinical conditions or clinical infections due to the dermatophytes we call tinea, which we commonly call tinea. So if tinea normally is a Latin words means ringworm, because the condition of tinea looks like a ringworm because it's annular in consistency at the peripheral sites. So and how we name the disease actually is based on another Latin word is on the location of the tinea infection. Let's say you have a tinea infection over the body, over the trunk. Normally we'll use tinea corporis. If there is a tinea infection, over the toe or the nail, we'll use tinea angum. Tinea curis will be at the inguinal region, or tinea capitis, which is commonly in our pediatric patients, will be a tinea capitis. So Tinea actually in one survey published by Pityriasis in a journal of dermatology, tinea is a skin condition most likely to misdiagnose by primary care physician. So I think we have a very high suspicion in children and even adult patients. When the patient come in with a skin condition, you have a high suspicion this may be is this of tinea or not. So in pre-pubertal children, normally the tinea infection will involve the body and also involve the scalp. But for adolescents and adults, normally you get a tinea cruris which will involve the inguinal region, tinea pedis over the foot, and tinea ungum over the nail base or the toe. So how we describe it, actually you will see that from this picture, you see there's a red annular margin, and also you have a very scaly, or this white region is actually very scaly, and they will have a pruritic patch due to the scratching of the patient, and there is a central clearing. So actually the central region actually is quite clear and looks less inflamed. And this tinea most of the time is itchy and commonly mistaken as eczema, psoriasis, and even seborrheic dermatitis. You can look at the picture there over the right lower end. So this is a few pictures shows this is a tinea capitis, which involve the scalp over the children. So you can look there as a gray patch, which is a very scaly, and this photo also shows there's a patchy hair loss. And when you look deep inside, actually some tinea capitis, there's also some very red dots over the hair follicle. It's a black dot over the hair follicle. In a severe one, which is the lowest picture here, there's a cheiron formation, which we call cheiron, with a swelling and bulginess. So generally, tinea capitis, you need a systemic antifungal. Okay, so the first line treatment is still topical antifungal, except tinea capitis and moxazine type of tinea pedis. Normally, I will suggest patients to use twice a day, at least for 4 weeks duration, include at least 1 week after the lesion has been cleared. So total can be 4 weeks plus 1 week, maybe up to 5 weeks. So you need to advise the patient to apply the cream 3 centimeters beyond the margin of the lesion. So you can able to adequately cover the active infective region. If not, you can get a very high chance of treatment failure. So, and also you need to advise the patients to be compliant to medication, because we know that most of the time, because fungal, you need a long duration of treatment. Some patients may not compliant to that. So a lot of time you have a treatment failure. So what's the indication for systemic antifungal agents indication? So first, it's a very extensive lesion. Let's say the area of the body with tinea is too large. It's very difficult for you to apply the cream throughout the body. So this is one of the indications we have to use oral medication or oral antifungal for the patient. Or the lesion failed to respond to topical preparations. Failed to respond, we have to consider oral antifungal. Definitely tinea capitis, which we have mentioned. Tinea involves the scalp, because when you apply the cream to the scalp, this cream is very difficult to penetrate inside the hair follicles. That's why when there is a tinea capitis, you need a systemic antifungal to take effect. And also moxazine type of tinea pedis. Moxazine type of tinea pedis normally is a very chronic athlete's foot, we say. So this type of athlete's foot of tinea pedis, you need a systemic medications to treat it. So next, let's look at this. Pityriasis Versicolor. So Pityriasis Versicolor is a condition. Parents will tell you, anak saya ada panau. So this is what is commonly seen More common actually in the darker skin patients. You see a lot of hyperpigmentation skin. Normally they will be located on the anterior chest or even on the face and also axillary region. So this Pityriasis Versicolor is caused by a fungal called Malassezia furfur. So this fungal actually most of the time they are non-itchy, but they just cause some cosmetically disfigure looks, hypopigmentation, and they can be getting spread bigger and bigger. So how you know whether this is a Pityriasis Versicolor? Here we can recommend a simple test which we call evoked scale sign. Evoked scale signs means you use 2 fingers, you stretch in and out a few times, and sometimes we also suggest you to use a scratch test. You use a spatula to perpendicular scratch on the hypopigmentation region, and after you do this evoked scale test or you use a scratch test, you see a scale lesion on the skin. So this will tell you the patient have a Pityriasis Versicolor. So what you can do if a patient have Pityriasis Versicolor? Pityriasis Versicolor is quite common in young children and even school-going age and also school-age children. The treatment will be, normally we can suggest a selenium sulfide lotion or shampoo, or you can even give a ketoconazole 2%, apply daily to the affected area 10 to 15 minutes before bath. So you leave it for 10 minutes, then you ask the patient to take shower, use this for 1 week duration. So intermittently also we can suggest the patient to use it once a month to prophylactic treat to prevent the recurrence. Also, you can try to use the azole cream, any ketoconazole, fluconazole cream. Apply it twice a day for 2 weeks. If this area is very large, this pityriasis is large, extensive, you can use itraconazole or fluconazole. So next we will have the look at the cutaneous candidiasis. So actually this is more common in adult patients, especially they are immunocompromised. But we do see in small children, especially baby, which they associated with a nappy rash. So this candida normally they occur in the moist, occluded cutaneous sites, which can be your axillary region, your inguinal region, intergluteal region, or nappy area. Because candida require warm and humid environment to grow. So what is the typical sign? Actually, we will not always tell if there is a satellite pustulosis. You can look at here, this picture on this baby nappy region, you see a multiple satellite lesion. This will tell you this child, this baby may have a candida infection besides a nappy rash. So you may need a nystatin cream or ketoconazole or fluconazole cream. You need to apply this twice a day for at least 2 weeks. Rarely, if an adult patients or immunocompromised patient, they have like just below the breast or axillary extensive lesion, then we can try a systemic therapy, either itraconazole or fluconazole. So next, we'll go to a nappy rash again, because this is a very common, especially in the children less than 2 years old. So you'll see parents will bring this type of baby to you, complain of redness over the perianal region or nappy region. This is mainly due to napkin not frequently changed enough, and infants have diarrhea or loose stool. This will definitely cause this nappy rash. Some cases actually, even though they have changed this napkin regularly, but they still get, because some infants or some baby, their skin is just sensitive to this urine or stool. So sometimes this is just an irritant effect of the urine to the skin. Not necessarily because they don't change frequently, because the skin of the baby is a little bit allergic to this type of irritant, especially the urine. It can be quite painful and itchy. And you will see there, normally if nappy rash, typically the flexure, you can see at the flexure here, in the inguinal flexure, they're typically spare because you at the flexure, you don't have a direct contact with the urine. Normally, you also will see a very erythematous scalded. In a severe one, you can see erosion with ulceration. Look at the picture at the upper end, upper here, up part. So this is a erosion with ulceration. So the treatment, I think all of you may know, you advise the patient to use zinc oxide, which is a barrier. And sometimes you can just prescribe a mild steroid. They are very responsive to mild steroid. Normally for me, I recommend you to use hydrocortisone because when you use a more higher potency one, let's say moderate to high potency steroid, not recommended because sometimes, because this is used to the nappy area, we worry sometimes you will have a systemic absorption. So mild steroid should be adequate. And always advise the parents not to use powder. Any talcum powder is not suggested because this type of baby, normally they have a contact dermatitis, irritant contact dermatitis. Even the powder you use, it can worsen the condition. And some pediatricians even will advise to avoid the alcohol-based wipes. I remind the parents to look at the ingredient or the content of the wipes, so it don't contain this alcohol base. So what is the difference between nappy rash and Candida nappy rash? So I think there's two main features here. First is the flexure. In nappy rash, the flexure are spared. If in Candida nappy rash, your flexure of the wrist or your creases will be involved. So in nappy rash, the rashes will be erythema and there can be severe erosion and ulcer. For Candida nappy rash, it will be beefy red papule. Sometimes we will have whitish scales you can see. The most prominent one, as I mentioned just now, for Candida nappy rash, you will find Candida satellite lesion. Satellite lesion at the periphery or at the margin of the skin. So you have to look at the satellite lesion. So because nappy rash is an irritant type, sometimes they're associated with cradle caps or even atopic dermatitis. So for Candida nappy rash, I would suggest you also to look at the oral lesion, orifice to see whether the patients have any oral candidiasis or not. If there is, you can use nystatin suspension. So let's look at the seborrheic dermatitis. Seborrheic dermatitis is a skin condition very common among baby, especially the first 2 months of life. So normally they have a very greasy scale, especially over the scalp. Sometimes they even involve the eyebrow. They are not itchy. This is a sign that you ask the parents, they are not itchy. But this will increase the risk of atopic dermatitis. So you can warn the parents, sometimes is this condition not improved, possible the patient will progress into atopic dermatitis. So the treatment actually is very simple. For me, normally I would suggest parents to buy just to use the olive oil. You just use the olive oil to just apply on the scalp and also the eyebrow. Actually, definitely you improve. You even can use a coconut oil. And there's also, you can use a selenium shampoo, but you use a milder form of selenium shampoo. And sometimes, occasionally, we can use a mild steroid. Mild steroid also is very effective in this type of seborrheic dermatitis. And ketoconazole cream, 1 to 2 weeks, is also proven to improve the seborrheic dermatitis. The good thing is seborrheic dermatitis, normally if you even don't treat it, you give a lot of assurance, actually within 1 or 2 months, they'll just improve by itself. Okay, so let's look at this atopic dermatitis. Atopic dermatitis is a very common condition in our pediatric patients. especially less than 1 month of age. So the prevalence in children will be around 10 to 20%. So atopic dermatitis, sometimes some physician or doctor, they use eczema. Actually, most of the time it's used interchangeably, but for officially, we may prefer to use atopic dermatitis. Atopic dermatitis to tell you that this is an atopic disease. So atopic dermatitis normally is a multifactorial. It can be due to personal, or they can be due to environmental, or also even genetic. So most of the time, atopic dermatitis, they may have a strong family history of atopy. So you can ask whether the parents have the skin itchiness or not during childhood, or siblings have atopic dermatitis before or not. So each itchiness is a key feature. You will look at the child, they're scratching around, very uncomfortable. And each scratch, each cycle is one of the prominent features in atopic dermatitis. So when you have atopic dermatitis, your excoriated area will become very red. So the baby will go to scratch, and you have a lot of weeping and serious discharge. So this weeping and serious discharge will cause will be crusted. And normally the distribution of the eruption change with age. When the child is before 1 year old, normally the distribution will over the head, will be over the cheeks, bilateral cheeks, and also the elbow. So atopic skin will have dry, prolonged dryness, and prolonged scratching and rubbing. Subsequently, you can see this type of patients, they have lichenification. Lichenification means there is a thickening of the skin. You can see a thickening of the skin, and there's mild hyperpigmentation, especially in the older patient or school-going children, especially on the flexure of the arm. So lichenification also is a key feature of atopic dermatitis. Okay, so atopic dermatitis normally is the first presentation of the atopic march. So as I mentioned, atopic dermatitis is a multifactorial. So and it's most of the time, sometimes we can say there's a lot of studies shows that this type of atopic dermatitis patient, they have impaired skin barrier. Because of this impaired skin barrier, due to this defect in the filaggrin gene, so they have persistent leak of the water from the skin. So this persistent water escape from the skin will cause this skin to be very dry. When the skin dry, it will become very itchy. Itchy, the child will go to scratch, there's a lot of scratching, and this causes itch scratch cycle. Furthermore, there's irritants like allergens and even microbes will enter the skin, which cause skin inflammations. This will further complicate the atopic dermatitis. So what is atopic march? Atopic march is mentioned that half of the infant with atopic dermatitis, later they'll develop asthma, maybe in 2 to 3 years. 2/3 of them, actually, they'll have developed allergic rhinitis. This is what we say atopic march. So when the patient has atopic dermatitis, maybe we want to follow up the patients for asthma, or even you want to follow up, ask any allergic rhinitis, you may need to treat them accordingly. So let's look at the distribution of atopic dermatitis by age. Just now mentioned, patients birth to 2 years, normally the distribution of atopic dermatitis will be on the face, scalp, and also the extensor surface. When the patient is in the childhood, 2 years to puberty, you'll see that this atopic dermatitis will go to the flexure, which at the flexure of the elbow, flexure of the knee, and also the anterior of the knee, anterior of the ankle. This is a typical distribution when the child 2 years to puberty. So, what is a key step in the treatment of management and management of the atopic dermatitis? First, there's two main things you need to concentrate. I think most of you men already know this, which we need to resolve the existing inflammation in acute flare. You need to resolve the inflammation, which you need to stop the fire. And second, you need to reinforce the skin barrier, because as I mentioned just now, when the patient has atopic dermatitis, you have continuously of water leak from your skin. That's why your skin will be very dry. So you need to build the brick. You need to build the skin barrier again. How you build the skin barrier mainly is emollient. So next, when the patient come in with acute flare, there's a few things you may want to ask, whether the patient have poor compliance to medication. If we know that when the patient have atopic dermatitis, they may need to use emollient, which emollient is the first line treatment in their daily. So they have to use the emollient every day. So you need to check the patient whether they're compliant or not. Second, you want to make sure there's no infection. So whether is there any signs of Staph aureus infection, or is there any herpes simplex infection? This can be a medical emergency, and herpes infection normally we call eczema hepaticum. Or is it complicated with a scabies infection? Next, you also want to ask whether the patient have a persistent contact irritant or allergen. Poor housing environment, therefore cats or dogs' furs, dusty environment. This can also cause the acute flare. Or is there any physical trauma? A lot of scratching, sweating. So you look at the picture at this left lower. This two pictures shows that this poor child, he have eczema hepaticum, because it's due to complicated by eczema herpes simplex virus infection on top of the atopic dermatitis. So when you see this type of skin condition, it can show you if this patient has eczema hepaticum, and this type of patient may need a urgent medical treatment, which they may need a systemic acyclovir. So, okay. So what is the 5 key plans? Key plans for atopic dermatitis mainly, first, as I mentioned, you need to stop the inflammation. You need to stop the inflammation. You need to stop the pruritus. So what we do, you can start the patients on steroid, emollients, and even you can consider oral antihistamine. Oral antihistamine sometimes can be used, either sedative or non-sedative, especially for children more than 1 year old. Hydrate the skin. Hydrate the skin, tell the parents to use the emollients as frequent as possible, up to 4 to 5 times per day, especially after bed. Reduce the inflammation. How we do that? You have to start the patient with steroid at least 7 to 14 days and control the infection. If there is a signs of pustular involvement or pustule, or the patient have fever, you may suspect Staph aureus infection. So normally we recommend you to start a first generation cephalosporin. You can use cefalexin, EES, or cloxacillin, or any penicillin group antibiotic actually is effective for Staph or Streptococcus infection. Try to avoid irritants. Tell the parents not to use irritant, especially those adult soaps or shampoos, and avoid tight garment. Try to use a cotton-based cloths, so have more ventilation. So skincare also very important. We have to advise the parents to bathe the patients 5 to 10 minutes with warm, not hot water, once daily, because this will smoothen out the skin and make the skin softer and reduce the itchiness. And also try to avoid skin soap. Try to avoid skin soap and moisture the skin with emollients at least 2 to 3 times per day. Do not use lotion, as lotions is not effective. You need to use emollient. Lotions is not good enough. You have to suggest the parents use cream. Cream is good, or emollients. So not to use lotion. Avoid organic product. Nowadays, a lot of parents they'll try to use organic products. Actually, these organic products sometimes because they are plants derivative. sometimes these plants derivative, they have some allergens. It can make the condition more worse. Or make sure the parents, this type of patients that don't take a lot of, or use a lot of organic products or organic soups like that, this can make the condition worse. Okay, I think this will be a few last slides. Scabies is a very common misdiagnosis among our pediatric age group patients, and that's why most of the pediatric patients, when you come in, you have a very high suspicions. Is this a scabies? So scabies is common, especially in young children. Differential can be atopic dermatitis. Sometimes you miss that we thought this is atopic dermatitis or staphylococcus skin infection or even herpes infection. First, you need to look at the burrows. This is a typical finding: burrows, papules or vesicles, and normally the patient will be very itchy, especially at night. So we can look at the photos, especially look at this patient's, the baby's legs. There's a multiple burrows, which is papules. This is scabies burrows. And look at this picture at the baby's hands. This is a burrows, small point red color one. This type of skin normally typically is scabies. Typically is scabies. So management wise, you need to treat everybody in the household, ask all the family members to your clinic and get anti-scabies. Advise them to wash clothing and bedding in hot water and sun. Give antihistamine if necessary to avoid a lot of itchiness. And also you need to treat the superimposed bacterial infection, because it's very common. We can see this type of patient, they have infected skin due to staphylococcus. Normally, you will look at the skin, they have a lot of pustule, pus contained. Yeah, this will tell you the baby or the child will have a bacterial skin infection. Normally, it's due to staphylococcus. Then you may need to treat the scabies at the same time. You start with oral antibiotics for the patient. So this is a slide I adapted from Malaysian Pediatric Protocol. Not sure whether you can see it very clearly. Basically, just to summarize the slides. So the first line treatment for scabies in pediatric patients is permethrin 5%. So just equip your clinic with permethrin 5%, because permethrin 5% is relatively safe and less side effect compared to benzyl benzoate. Benzyl benzoate sometimes we concern of the neurological side effect. So permethrin 5% you can use to any age group of patients. Okay. So I think this is the last skin condition we need to mention. So impetigo. Impetigo is a common skin infection, come to either a pediatric clinic, I think even a GP clinic. So this is a superficial skin infection by Staphylococcus or group A Streptococcus. You can see here, normally this type of skin, normally they are localized. They're either localized at a certain part of the body, but commonly they are at the face. You can look at this picture. This will be at the angle of the mouth, at the face, or over the nostril. So most of the time, patients also have pre-existing skin condition like atopic dermatitis. Initially, you will see erythematous macules. Then they will form a vesicle. Look at this picture here. At the baby's abdomen, they have vesicle. This vesicle, after rupture, you'll come out with exudative fluid. This exudative fluid will be presented with a honey-colored crusted lesion. This is a typical presentation or typical finding of impetigo. If you look at this honey color, look like tasty color, then this is an impetigo. So you need to treat this with antibiotic. So look at this picture over the right side, right lower. So this is a bullous. You can see here is a very big one and already ruptured. So this is a bullous impetigo. Bullous impetigo is slightly different from just impetigo because the management is different. As long as you have a patient with bullous impetigo, you need to start the patient with systemic antibiotic. Either you use oral antibiotic or you use IV oral antibiotic. And okay, then we can concentrate a little bit on impetigo. This is a recommendation from NICE guideline. So we can see here, the topical antibiotic we use normally as recommend will be fusidic acid or mupirocin 2%. That is for impetigo. Systemic antibiotic is indicated when your lesion is very big. It involves your oral cavity, or your face or your body. Then you may consider systemic antibiotic. You can use the first choice. Normally we recommend cloxacillin, or you can use EES or clarithromycin. So bullous impetigo and impetigo with patients who are systemically unwell or with high-risk complication or immunocompromised patient, you need to give the patients oral antibiotic or IV antibiotic. For me, I recommend a 7 days of antibiotic. Some guidelines they just mentions 5 days, 5 to 7 days. I prefer, I think we just give a 1 week antibiotic for impetigo. So you need to advise the patients, your children, should not go to nursery or school until the lesion are dry out, because this is a very infectious skin disease. Okay, I think we end here, and I finished my presentation, and this is some of my reference. Is there any questions? If there any question, you can put down in our chat here. Yeah, if you have any question, and I can answer it. Okay, so question from Dr. Tan. So what are the common causes of macular rashes generalized? Macular rash means this rash is not palpable, right? Papule normally is palpable, is raised. Macular rash, there is a lot of common skin condition can be macular, especially viral induced. I will say viral induced. Any viral exanthem, actually most of the viral exanthem, they are more to macular rashes. So when the patient come in with a macular rash, and you have make sure they don't have other underlying skin disease, they just come in with macular rashes, sometimes unwell with fever. So most of the time there will be either viral exanthem, and you have to make sure this is not a notifiable disease, not a typical measles. Then you need to escalate the case for further management. So I think for macular rashes in pediatric patient, most of the time is still a viral exanthem. And what rash does insect bite usually cause? Actually, insect bite it can be macular papular also, but most of the time is still urticarial exclusively, because this is due to the immunologic response or some hypersensitivity response. That's why most of the insect bite, actually, if there is a rash, most of the time there will be urticarial rash, which is a palpable raised view type of rash. When to refer, I think if your patient is systemically unwell or any infective cause of skin disease, I think you should refer to nearest hospital or pediatrician. So, or the patients went to you just for some skin disease, and you have tried once and the treatment have failed, I think you can refer to us for further input. So another questions, what do you use for milk allergy dermatitis? So actually, milk allergy dermatitis, in this case, most of the time, there is no specific treatment for the skin, because you need to treat the milk protein allergy. So you need to treat the milk protein allergy, means you need to confirm the diagnosis of milk allergy. and you need to prescribe the baby with a proper fully hydrolyzed formula, which is a very special formula. And once you have treated this milk protein allergy, the dermatitis will subsequently improve. But sometimes you can use some mild steroid to treat this allergic dermatitis on the skin, because we can see that from cow's milk protein allergy, they're also associated with atopic dermatitis. So the treatment of cow's milk protein allergy associated with atopic dermatitis, that is correlated. So that is why the treatment for cow's milk allergic dermatitis is quite similar to atopic dermatitis. Good emollient cream. Actually, they market a lot of a good emollient cream. You can try. I wouldn't do any recommendation here. What type of soup for eczema patient? What type of soup? You just need to make sure your patients they get a soup which is medicated free. Actually, from the market, there is a lot of good brand and established brand. This type of soup, especially as long as there is fragrance free and medicated free and paraben free, actually is quite safe for eczema patient. And most of the time, actually, because eczema patient, they have a lot of allergy. You need to ask them to try it and see. Sometimes they'll just improve after you use the soup. Sometimes it can get worse. You need to advise the parents accordingly. To look out for, because they can be allergic to any type of products. So sometimes they just have to try and error. From Dr. Guat Sin Chu, do we need to treat erythema toxicum? No, we do not need to treat erythema toxicum. If you find that this is a very typical erythema toxicum, and the patient is totally well, the baby is well, feeding good, no fever, as I mentioned just now, erythema toxicum treatment is just reassurance. They resolve within 1 week of life. You need to reassure your patient. You don't use any steroid cream or any emollient cream. They can worsen the skin condition. Do you recommend allergic tests for chronic eczema patient? From Dr. Nurul, do you recommend allergic skin tests? Allergic skin tests for chronic eczema patients is not really recommended unless we find out the patient have other atopic disease. Normally, allergic skin test is not really recommended. Is lotion containing ceramide superior for treatment? Ceramide may be slightly better because the ceramide will provide a barrier to and also smoothen the skin. Sometimes definitely ceramide will be better treatment for eczema. Anyway, I think the market now, they have a lot of products. So sometimes there's a lot of sales that will come around, and they even have a non-steroidal cream for eczema. So this type of cream also actually is good for eczema patient. So I would like to pass the mic back to Valerie, our marketing executive.